Hello, my name is Dr. Zachary Macchi. I'm a behavioral neurologist and neuropalliative researcher at the University of Colorado Anschutz. And today I want to talk a little bit about a recent study that we did looking at the validity of the surprise question for prognosis and prognostication in Parkinson's disease and other Parkinsonian disorders. As you may know, Parkinson's disease is a fatal neurodegenerative condition that has a long protracted course. And this can complicate prognosis as symptoms can wax and wane, and progression is often marked by periods of acceleration and disease stability. So we aim to look at the use of the surprise question, which asks clinicians to use their clinical judgment in estimating 12-month mortality, and simply asks, would I be surprised if this patient were to die within the next 12 months, yes or no? This question as a tool has been used in other non-neurologic diseases with some modest accuracy, and this includes in advanced heart failure and stage renal disease, as well as cancer. But we aim to look at the validity of the surprise question when used by community neurologists in prognostication for patients with Parkinson's disease and other Parkinsonian disorders. And so we leveraged baseline data from 359 patients and 34 community-based neurologists from a clinical trial of outpatient palliative care for Parkinson's disease and Parkinsonian conditions. Prior to enrollment and at baseline, all patients underwent a needs assessment using the brief needs assessment tool for Parkinson's disease. Item number one on this tool is the surprise question. And so all referring and participating clinicians did a screen of needs assessments and as part of that, looked at the surprise question. We decided to analyze the sensitivity, specificity, and predictive values of this question, as well as look at the survival analysis comparing surprise question responses. What we found was that overall mortality in our cohort of 359 patients was approximately 10.3% at 1 year. We noticed that there was relative good sensitivity for the surprise question with some modest specificity, a poor positive predictive value for predicting death. However, for those who answered yes, I would be surprised, meaning they would be surprised if a patient passed away, there was relative good negative predictive value in estimating in using the surprise question in this manner. We found that the surprise question was modestly accurate with an area under the curve of approximately 0.7 and a hazards ratio of approximately 3.69 at 12 months. In general, the clinicians who answered these questions, the 34 participating neurologists, were approximately half trained in movement disorders and were affiliated most often with non-academic, community-based, independent and network multi-provider offices. So future studies should consider the context of the surprise question. We found that it was modestly accurate. However, more research is needed for its use in conjunction with other needs assessment tools. It may be that the use of the surprise question could be a trigger for evaluating for palliative care needs in general, even if mortality is not estimated to be within a year's time. Additionally, we are interested in looking at the surprise question when used by advanced practice providers, nurses, social workers, other ancillary staff, as well as when used by geriatricians and primary care providers, so non-neurology trained physicians and providers. So while the predictive value is limited, it may secondarily assess for addressing unmet care needs that may be perceived as contributing to mortality. And so more research is needed to understand the context, the utility, as well as the ease of using this tool in conjunction with or without a needs assessment that is comprehensive and looking at specific palliative care needs of patients and caregivers. With that, I appreciate your time for hearing my summary and our study, and I'm happy to answer any questions that you might have or other comments that you might have about this work. Thank you again for your time.
Thank you very much, Zach, for that. It seemed to me that the surprise question got people thinking about what the patient's needs were, and that was the most important use of the question in some ways. Would you look at other systems to try and look at needs like IPOS or the other many systems there are?
Definitely. And it's actually interesting that you point that out because the context of the surprise question being given to clinicians in this study in particular actually was in conjunction with a brief needs assessment tool, one that had been used in uh, uh, at least two clinical trials to evaluate for palliative care needs in Parkinson's and Parkinsonian disorders. And so the surprise question was actually the first question that clinicians asked as part of that needs assessment tool. And yeah, if anything, it gets the ball rolling as far as having clinicians sort of think about, what exactly is going on in this situation that we can address. And the surprise question, of course, is touching on, is there a clear end of life care need or hospice care need? But at least it's sort of that jumping off point in this situation, in this study, for thinking about other aspects of the care that they're receiving. So caregiver burden, other complex symptomatology that needs to be addressed, and other sort of psychosocial issues. So less to say, it'll be interesting to see in future research if the surprise question by itself, separate from other needs assessment evaluations, is any better or any worse. So estimating mortality.
Thank you. We've got a couple of questions come in. One is, please explain the positive predictive value of the question. Does it mean it is surprised if the patient dies?
Yeah, so the positive predictive value was looking at if clinicians responded, yes, I would not be surprised. So essentially asking the clinician is responding and saying, yeah, I expect that that they would pass away in the next 12 months, or at least I would not be surprised. And so a lot of clinicians answer that they would not be surprised if the patients passed away. And so in that way, the positive predictive value was pretty low. People were sort of overestimating the number of people who would pass away in the next year. And so, whether that's because, of the context in which this was being administered, this needs assessment tool is actually part of the screening process for enrolling patients in that clinical trial of palliative care. And so, they were already sort of maybe thinking that patients were sort of at the end, and a lot of these patients tended to be more advanced than sort of the general Parkinson's patient population. So yeah, in that way, people were or clinicians were kind of overestimating, how many people or how the mortality that was present, it seems like, and that's sort of reflective in that positive predictive value being so low.
Thank you. Another question here, interesting, thank you. I think you said your plan to look at comparison of accuracy when used in non-neurologists, primary care and geriatricians a priori. Do you think they will be more or less accurate than neurologists?
That's a great question. And I mean, my sort of knee-jerk answer is to say that they'd be less accurate because, these are not conditions that make up a bulk of primary care practices or geriatrics. Not to say that, they aren't taking care of these patients, but, neurologists are, in an interesting position where they are, dedicating a lot of their time and efforts to taking care of patients with these conditions. And so just having more experience with it, I think probably would make it more accurate for neurologists as opposed to non-neurology trained practitioners. Again, that's something that research is needed to really show, but that's sort of my hypothesis moving forward, seeing how neurologists perform even using this question.
Right. Yeah, it was a geriatrician who asked the question, so I don't know whether he would say that actually
Sure, yeah.
they were more aware of other aspects of patient care, or so you could argue it both ways.
Yeah. Oh, totally.
And one of the other comments here, most of the discussions here relate to PD and looking at end of life. Would it be more effective to have early intervention at the time of diagnosis?
Absolutely. Yeah. We're learning more and more about the role of palliative care throughout the disease, span. And a lot of literature and a lot of research being done is showing that early intervention, early referral is likely the way to go. And certainly the surprise question touches out on those end of life aspects of palliative care. But yeah, I mean, the idea that palliative care should be instituted even well before we're even considering mortality, I think is something that's emerging and evolving, and is becoming more and more of a reality for the way we understand how palliative care for Parkinson's should be implemented.
Do you think the surprise question might help professionals and families and patients to start thinking about the future and making preparations or talking together.
Absolutely. I think if anything, yes, this question gets at mortality, but kind of going back to what I had talked about before, serving as sort of this trigger or jumping off point for having a deeper discussion about, what the future does hold. Because if you're thinking about mortality, even if you don't think, your life expectancy is a year or less, it still gets you thinking about this topic just by asking the question. And I think if anything, it's sort of an easy, quick way to get the ball rolling or start thinking about these bigger issues. Because everyone with these conditions, at least at this point, without a cure or treatment to reverse or stop these processes, is going to eventually get to the point where they need end of life care and hospice. So I think at least this serves as a jumping off point for thinking about these things well in advance.
Thank you very much indeed, Zach, and thank you to all the presenters this afternoon. Do take the opportunity also to look at the other posters. There are some really interesting posters in the poster section. That's the end of the session. Thank you to everyone. And the next session will be in 15 minutes, which is engaging as an advocate, the patient perspective, when we'll be hearing from Randy LeBlanc and Brian Wallach. See you shortly. Thank you very much.